Hi, I'm Dr.N.Komagan Prabhu, Associate Professor from Department of Oral Maxillofacial Surgery, SRM Dental College. I'm going to discuss about the topic on dental treatment for patients on anticoagulants. So, patients on anticoagulants are a challenge for all of us. It's because of the reason that it leads to prolonged intraoperative and postoperative bleeding, which is a major concern on these patients who are on anticoagulant therapy. So, these patients need to be thoroughly evaluated with proper medical history. So, and also the associate comorbidities for the patient who is on blood thinners have to be properly documented. So here, a proper investigations on coagulation profile have to be interpreted before the surgery. So coming to the prophylactic role of these anticoagulants, they are often given as a prophylaxis for patients who are at risk of thrombus formation. They basically are patients who are acquired or hereditary medical disorders such as coronary artery diseases, atrial fibrillation, deep venous thrombosis, patient with prone for stroke, cerebral venous thrombosis, and pulmonary thromboembolism. These patients are of urgent basis, they are all put on long-term anticoagulants. And also patient on cardiac bypass surgery, hemodialysis patient, and disseminated intravascular coagulation profile cases, where the coagulation is put on a brief period, and sometimes they are put on a bridging therapy such as low molecular weight heparin. In patients who have undergone valve replacement, for them it is not of urgent, but anticoagulation therapy is also initiated. What are some of the anticoagulation drugs that are commonly prescribed? Most commonly is the coumarin derivative or acinocomarol, where warfarin sodium comes under this category. It has a half-life of 48 to 72 hours. It's an anti-vitamin K anticoagulant. The other being enantium derivatives, they are known to cause hypersensitivity reaction. The newer oral anticoagulation drugs, which is commonly prescribed nowadays, are the dabigatran xylate, which is a potent inhibitor of free thrombin, which prevents the coaggregation of platelets. The other drugs being rivaroxaban and apixaban, which are selective factor activated 10 inhibitor. So basically, we should be knowing about the coagulation cascade because these drugs they act directly on the factors which directly helps in the formation of clot. The basic mechanism of action for heparin is that it potentiates the action of thrombin 3 and warfarin, which will be preventing the maturation of vitamin K dependent clotting factor, which happens to form in the liver. Ultimately, the conversion of fibrinogen to fibrin is terminated or it minimized so that the clot formation is negative. The antiplatelet mechanism of action being they're all COX-2 inhibitors. Drugs like aspirin, they block the thromboxane A2 production, thereby inhibiting the cyclogenous activity and subsequently platelet coaggregation is prevented. Drugs like diclofenac, clopidogrel, they inhibit the platelet aggregation by blocking adenosine diphosphate to its platelet receptors. Drugs again like dipyrimidine, they are potent adenosine receptor inhibitors. There is a drug which is a dual antiplatelet drug therapy is being initiated, which are antithrombotic regimens which consisting of low dose acid and P2Y inhibitors such as clopidogrel. Always we should take in, we all should note that the risk of thrombotic events by altering or discontinuing these drugs or a dual antiplatelet therapy will far outweighs the lower risk of post-operative oral bleeding. That means we can easily arrest the bleeding by local hemostatic measures. The role of low molecular weight heparin, it is being that it is used as a prophylaxis of venous thrombotic diseases. They basically inhibits factor 10A and 2A in the coagulation pathway. They basically are used as a bridging therapy. So a low molecular weight heparin, when it's given as a subcutaneous injection for a period of 10 to 12 days during the time of the surgery, the warfarin is first interrupted and it is being continued so that the anticoagulation effect is outside the therapeutic range. We've been talking about the new oral anticoagulant drugs. Some of these are the dabigatran, rivaroxaban, apixaban, and endoxaban. They exhibit a rapid onset of time and prompt withdrawal of anticoagulation effect. So the result being rapid action and short half-life, there is a decrease in the predictable anticoagulative activity compared to the warfarin or other anticoagulation drugs. And also they found to have less drug interaction and can be which are less affected by the diet. The new oral anticoagulant drugs are direct thrombin inhibitors and directly affect the factor Xa inhibitors. They inhibit the coagulation by directly binding to the thrombin, which prevents the formation of fibrin, which aids in the clot formation. So thereby they restrict the thrombin from breaking down into fibrinogen. So the drugs which are commonly prescribed will have certain interactions with each other. So we should always, whenever we see a prescription, we should all when we prescribe drug, on patients on antibiotics, we should avoid certain drugs. So commonly when patients on warfarin or penidione or acinocomerol, they are highly having a drug interaction with common drugs like amoxicillin, metronidazole, erythromycin, and clarithromycin drugs, even aspirin for that matter, and diclofenac. So what happens is that when we give these, it potentiates more bleeding. And some of the oral anticoagulants like aspirin, clopidogrel will also have a found to have a good profound interaction with ibuprofen, diclofenac, and aspirin, but have a less interaction with erythromycin and carbamazepine. The newer oral anticoagulants are found to have less interactions, but provided we also should be very careful in this in prescribing drugs like aspirin, ibuprofen, diclofenac, and carbamazepine. So what is the prevailing dilemma whether to continue anticoagulation therapy during surgery or not? There is an earlier protocol of temporary discontinuation of the anticoagulation, now which has been currently modified by decrease in the dosage of anticoagulation and substituting with low molecular weight heparin without altering the anticoagulation regimen. So there's a need for thromboembolic risk stratification. So we should categorize patients into low thromboembolic risk and high thromboembolic risk. So patients who are atrial fibrillation with a CHAD score, which is a scoring which is given for patients on coronary artery disease. So a score which is considerably 0 to 2 or 0 to 4 will be of low thromboembolic risk. Patient with score of more than 3 to 6 or 5 to 9 will fall under category of high thromboembolic risk. Patient with potent or prosthetic heart valve without high risk features fall under low thromboembolic risk, and patient who are on prosthetic heart valve within the 3 months of visit falls under high risk features. And patient on coronary stents after 1 year of antiplaque therapy is safe to be managed. Then patients who are within the falls under category within the past 1 year or few months time. So nowadays there's a need for us to stratify the patient into high and low risk. So coming to the dental procedures that can be followed safely are that this, which is being low risk, are the simple extraction like say a case of involving just extracting 1 to 3 teeth falls under low risk. IND with detailed 6-point full periodontal examination, subgingival and root surface instrumentation, restoration with subgingival margins all falls under low risk of bleeding. Okay. High risk being patient with complex extraction, which where we do an open method of extraction that there incorporates the flap raising procedures and periodontal flaps procedures, periradicular or episectomy procedures, crown lengthening, and biopsies. So low risk being a common infiltration techniques or patient to give a block, so infiltration or nerve block and basic periodontal examination, especially should carry out a supragingival scaling, restoration with supragingival margins, endodontic treatments, impression and other prosthetic procedures, and adjustment of orthodontic appliances all falls under low risk of bleeding. The common lab tests or monitoring that needs to be performed or which we need to take for all the patients is that activated partial thromboplastin time, which is a normal value of around 33 to 45 seconds. Prothrombin time should be of 12 to 14 seconds. Bleeding time of less than 9 minutes. and gold standard being the INR, which will be falling under the 2 to 4 level, and thrombin time to 12 to 19 seconds. Platelet counts being 1,50,000 to 4,50,000 is a basic blood profile that needs to be monitored prior to the procedure. International normalized ratio is the gold standard of investigation. So this is considered to be the best for patients on anticoagulation therapy. Okay. So what is INR is nothing but it is taken by patient procurement time by mean normal range. So an INR of 2 to 4 is considered to be safe. So what is the management algorithm for patients with anticoagulation therapy? So an INR can be documented on the same day if the patient falls under the normal level of 2 or within the range of 3 to 5. Minor intervention, if it is proceeded, need not have to alter oral anticoagulation. With hemostatic measures, we can proceed. A major intervention, in that scenario, you need to suspend the drug for 2 to 3 days and you can replace it by low molecular weight heparin. And once it is continued, you can reset the oral anticoagulant after 12 hours. If it is greater than 3 to or 5 beyond INR values, you can postpone the intervention. So what are the basic hemostatic measures you can have it in side by side is that tarantinic acid mouthwash is found to be very effective. It inhibits the plasminogen activation and causes fibrinolysis. Fibrin glue or factor 13, which is present as the fibrinogen component of the glue, stabilizes the clot. Gelatin sponge is a reabsorbable collagen sponges can be easily packed within the extractor socket. Surgicel is another hemostatic which comes in handy. It's an intraalveolar oxide cellulose and basic suturing will prevent bleeding. There are a lot of literature which documented the effect of anticoagulation therapy, and most of them suggested that anticoagulation or antiplaque therapy should not be suspended for common dental procedures. Okay, elective dental procedures should be avoided for 6 weeks after myocardial infarction or cardiac stent. A study which is found common in literature, is that they suggest that dental extraction may be safely performed on patients who have an INR value of less than or equal to 3. Wall established the following points in the study. The risk of hemorrhage after dental extraction is very minimal, provided the patients are maintained at a therapeutic level of anticoagulation. There's no well-documented case reports of serious bleeding or complications following dental surgeries. There are several documented cases of serious embolic complications who are on patients on warfarin therapy when warfarin therapy was withdrawn. So, to summarize, you should properly evaluate the patient with a detailed case history. You stratify the patients into low and high risk group, document and assess the anticoagulation medication that are being followed, a basic communication that have to be undertaken with the physician or cardiologist for high risk patients. This is a very important thing that as a dental fraternity we all should follow. And prior lab investigation needs to be undertaken and assess the coagulation profile carefully. And adequate chassis hemostatic measures needs to be taken. Thank you. So with this, you all would have got an insight on how to manage the patient on anticoagulation therapy.